Hello and welcome to today's webinar, Inroads into Polypharmacy, Updated Strategies and Practical Measures to Mitigate Risk, sponsored by Elsevier's Clinics Review articles and Clinics in Geriatric Medicine. Please note your line will be muted and the presentation will be recorded. You may submit questions at any time using the Q&A feature located on the right. Today's presenter is Zagaria, Clinical Consultant Pharmacist in Geriatrics at MZ Associates. Dr. Zagaria practices as a medication specialist serving adults in a variety of practice settings and is extensively published both nationally and internationally. Dr. Zagaria inaugurated the monthly Senior Care Pharmacy column in the peer-reviewed journal U.S. Pharmacist, which he continues to write to date. He has presented on Capitol Hill, briefing congressional staff about implementing medication therapy management, and was an invited at-large delegate for the Pharmacy in the 21st Century Profession-Wide Strategic Planning Conference. He was an appointed member of the Dean's Advisory Council at St. John's University College of Pharmacy in New York City. He is a board-certified in geriatric pharmacy and completed a behavioral disorders traineeship at McLean Hospital in Belmont, Massachusetts. Now, I would like to turn it over to Zagaria. Dr. Zagaria, please go ahead.
Well, thank you all for being here, and thank you to Elsevier as well for their support of this webinar. Recently, I was involved in a project in which I brought together clinicians from various practice settings for a comprehensive and practical look at polypharmacy. And so today, I'm hoping to pique your interest and help our interprofessional audience recognize the problem of polypharmacy as it exists in various clinical practice settings, and also to identify specific opportunities to mitigate that risk. And then lastly, describe updated tools and some strategies to enable us to reduce the risk of polypharmacy. With regard to our clinics project, we understood that the clinicians that care for older adults really strive to improve quality of care, but they do indeed struggle with the ongoing burden of polypharmacy. And they also struggle to a great extent with the balance between under-prescribing and over-prescribing, with guidelines and best practices. So in today's environment, there are select factors that can actually further increase and complicate polypharmacy-related problems, and that is that there's an ability for patients to purchase medications online, and that's been the case for quite some time. And this is really troublesome because many of our seniors really struggle with affordability of medications, and as they go to the internet to try to save money, they really do put themselves at great risk with regard to medical product safety. And also, the channels through which they purchase these medications do not carefully monitor quality or indeed the quantity. So when we talk about monitoring quality, we're really talking about adulteration of the medical product and counterfeit medications, a huge problem for the medical product safety chain even today. And when we talk about monitoring quantity of drugs, we're talking about these channels that don't monitor quantity, and so things like adherence slip through the cracks. Duplicative therapy is not able to be identified, and also overdose risk to a great extent. So what we know is that there is a huge problem with government staffing at ports of entry, at mail facilities, and also at international courier hubs. So I wanted to address these other factors that complicate polypharmacy in addition to the actual medications themselves. And so the Clinics project aimed to provide strategies and practical measures, but also tools and insight to the clinician's perspective related to polypharmacy, and also to address relevant issues for clinicians, and so we targeted physicians, pharmacists, nurse practitioners, and physician's assistants, RNs, these individuals who serve older adults. But we also wanted educators, such as preceptors and academicians, and even those involved in staff development, in addition to those who develop public policy and also guide public health campaigns. So this project was indeed comprehensive and at the same time practical for the practitioners and clinicians. So in the time allowed today, the following is just a sampling of that particular project. So I'd like to begin with polypharmacy qualitatively defined. Now, our contributor, Levy, has addressed trends in medication use, and that is in the U.S. in older adults. And what we have found is that the use of 5 or more medications in those 65 and older has really changed from 13% in 1998 to 39% in 2010. Those individuals taking 5 or more medications, those are prescription medications, between the age of 62 to 85 has changed somewhat indeed from 2005, 31%, to 36% in 2011. Interestingly, what we've noticed is that for those that take 1 or more OTC medications between that same age group, that has actually decreased from 2005 to 2011. And individuals that use dietary supplements has actually increased also to what I would consider a considerable amount, from 52% to 64%. And so I wanted you guys to have a look at these trends so that we know that this issue is not going away anytime soon. So how do we define polypharmacy? Well, there really is no single accepted definition. We see that it is defined numerically or qualitatively. And the numerical definition is often seen in research protocol and also in a variety of practice settings. Commonly, the 5 or more definition, 5 or more medications, is commonly used in literature. But it really is considered way too simplistic. It also is not necessarily problematic. There are many individuals that are on 5 or more medications, and they're managed appropriately. They're doing fine, and they're reaching their therapeutic outcomes. So what we have found is that Levy has indicated that this term appropriate polypharmacy has evolved from this situation. So the term appropriate polypharmacy could in fact be considered really optimized drug therapy for a particular patient, so that if the treatment is evidence-based, if there are appropriate indications for use, and if the treatment is carefully monitored and certainly ongoing, then therefore we could say that qualitative definitions are in fact helpful. So the proposed qualitative definitions of polypharmacy are either the use of more medications that are clinically indicated, or the use of unnecessary or harmful prescribing. So you can see that, once again, using more medications than are clinically indicated or using unnecessary or harmful prescribing, in fact, tells us that this qualitative definitions are certainly helpful versus just the numerical definition of polypharmacy. Which brings us to the 2 most widely used explicit criteria regarding an appropriate medication use, specifically in older adults, and they are the American Geriatric Society Beers criteria, and the screening tool of older people's prescriptions and screening tool to alert right treatment. So that's the stop and start criteria. Both of these criteria are updated recently. They are tools that highlight medications for which the risks often exceed benefits in the older adult population. They help us with situations in which potentially appropriate medications should be considered. And that brings us back to the notion of the balance between underprescribing and overprescribing. Their application has the potential to significantly affect patient care, and certainly clinicians should become familiar, at least with both of these documents. So many of you in our interprofessional audience are very familiar with these tools, but just to review, what we're talking about are criteria regarding drugs to avoid in specific conditions or disease states, and drugs to use with caution, so that if you need to choose those medications, we're going to be doing it with close monitoring if they are in fact unavoidable. So the American Geriatric Society list has been updated in 2015, and the stop-start criteria currently a 2015 version 2. Two updated tools for use in polypharmacy. So next, I wanted to talk about ICU, delirium, and polypharmacy. And so what we know is that in critically ill older adults, delirium is a prevalent issue, and that upon admission to ICU, polypharmacy is a common sequelae. So importantly, Gorpestat and Devlin have pointed out that medications commonly administered in the ICU do in fact remain modifiable risk factors for delirium in that setting. They do suggest, as a strategy, that prior to an antipsychotic medication trial, non-pharmacologic measures should be attempted. So for instance, early mobilization to get someone up, get them oriented, that in fact as a non-pharmacologic measure should be attempted prior to the introduction of an antipsychotic agent in the ICU setting. So in clinically ill older adults, polypharmacy and adverse drug events associated factors are outlined by these authors, and they indicate that failure to avoid high-risk drugs, failure to screen for pain, sedation, and delirium all can lead to the polypharmacy or adverse drug events. Additionally, not accounting for age-related pharmacokinetic changes can also put the individual at risk, in addition to those critical care-related pharmacokinetic changes as well. Failure to regularly down-titrate medications or discontinue them. So really decreasing the burden of medications overall in this individual that's in this ICU setting, failure to do so can put them at risk. Failure to recognize medication-related adverse drug events, and so not just attributing a mental status change to delirium, but rule out the possibility of an adverse drug event. Failure to consider medication reactions from withdrawal. So for instance, a patient that's been receiving a benzodiazepine long-term, admitted to the ICU and suddenly not receiving it at present, undergoing a medication withdrawal reaction. And so these are things that need to be in the forefront of one's mind when evaluating delirium in this setting. And lastly, the consideration of any pre-ICU medications, whether they be over-the-counter agents, alcohol, herbal supplements, or recreational drug use. So I think it is important to note that we should not be automatically ruling out illicit or recreational drug use in our elders. Further, Garpestad and Devlin have pointed out that the lack of certain involvement can actually put patients at risk for polypharmacy and adverse drug events. And they indicate that the daily involvement of a pharmacist, a critical care pharmacist in ICU, is helpful. So the lack of one can really pose a risk, in addition to the lack of involvement of family and friends. And so providing, familiar individuals to those patients so that they are provided with comfort, they're provided with, really the staff is provided with medical history about the patient is very important. And so once again, lack of this information and presence can place these individuals at further risk. And of course, medication reconciliation from discharge is really another way that we can, in provision of same, decrease the risk of polypharmacy and possibly adverse drug events. The initiation of a new medication to treat a side effect of another medication is a very common risk for polypharmacy, one that we refer to as the prescribing cascade. And individuals in the ICU are also at risk for that situation. And finally, the reinitiation of a medication that had been stopped prior to ICU admission is also another risk to polypharmacy and adverse drug events. And so in terms of actual strategies to recognize, reduce, and even prevent ICU delirium, Devlin reminds us to review the medication list for medications that are known to potentiate delirium. So we need to avoid not only polypharmacy in general, but specifically agents from categories such as the anticholinergics. And it's not purely anticholinergic agents, but drugs that in fact have anticholinergic activity. So when we look at a cardiovascular drug, we would be looking at a drug like amiodarone, placing someone at further risk. The benzodiazepines, they may not be able to be avoided in the ICU setting, but certainly their use for sleep would be a good thing to avoid in the ICU, as well as the non-benzodiazepine sleep aids, and also metoclopramide. So we would want to discontinue or, in fact, replace with a medication not known to cause delirium. Continuing, we would need to then look at dosages. So the lowest effective dose of a corticosteroid is in the best interest of the patient to reduce the risk of polypharmacy and adverse drug events, as well as the lowest effective dose of an opioid, central nervous system analgesic. We would want to, in fact, optimize the non-opioid analgesic in this regard. We would want to consider medication withdrawal effect. We spoke about that earlier. And also, when it comes to drugs that are necessary and cannot be avoided or discontinued, we want to ensure the ongoing assessment and monitoring. So, for instance, of antibiotic therapy, of which some can induce delirium. So we know that quinolones and macrolides, among others, can be problematic. So we want to closely assess and monitor for continued need. Also, a diuretic. Then it may not be able to be avoided, and so we want to closely monitor for dehydration and electrolyte abnormalities that can certainly compound the experience, the negative experience in an ICU. And then, of course, consider other anticonvulsants if delirium occurs with levetiracetam. And so what we just reviewed underscores the need for medication reconciliation during transitions of care. And our project's author, Guin, provides insight in this regard. In terms of guiding principles, we're going to be looking for the most accurate list of all the medications a patient is taking. And we also want to acknowledge that medication reconciliation during transition of care for older adults is in fact a complex process. Guin tells us that effective communication and coordination of care is one priority that pertains to transitions of care and medication use according to the National Quality Strategy. The Agency for Healthcare Research and Quality, Health and Human Services, and the World Health Organization have developed guiding principles to MedRec, and they do contain evidence that are pertinent to the long-term care and assisted living facility setting which serve older adults. And so looking at a comparison of guiding principles regarding the process of medication reconciliation, Guin notes that AHRQ recommends developing a single med list that should be shared by all disciplines, and it should contain the patient's current medications. The World Health Organization guides us to provide an up-to-date and accurate med list, and they do note that it's essential to ensure safe prescribing really in any setting. So of note, one important issue is electronic health records, and it seems to really distill down to cost. So there is a cost issue in long-term care and assisted living facilities. The barriers to nursing homes developing electronic health records is cost, but it's not just the initial cost for setup. It's for the maintenance and ongoing upgrades. It's also related to the lack of financial incentives to implement EHR, and also, and absolutely, a lack of technical staff in these long-term care and assisted living facilities. And frankly, we find the same thing that occurs in residential homes for the intellectually disabled as well, where we're seeing older and older individuals living longer in these settings, you know, through medication therapy. We are actually monitoring the intellectually disabled seniors in an environment where we do not have those up-to-date lists, perhaps, and the availability of electronic health records so that all disciplines are looking at the records in real time. So the proposed CMS rules from 2015 address patient care summaries that need to go to nursing homes receiving a patient during transition of care. They do not require electronic health records, but they promote the adoption and the use of computerized systems. Another polypharmacy-related area of discussion in our project is Deprescribing. And we focused on protocol, communication, and a patient-centered approach. Holmes and Todd addressed Scott's recent JAMA reference regarding a 5-step approach for a sequential deprescribing protocol. And so for each medication, we want to ascertain the reason for use, the overall risks for possible harm, current or future potential for benefit versus the likelihood for harm. And in this regard, we're going to be discussing, and communicating with patients and their families and their caregivers, or what we're seeing called care partners. Also, very importantly, prioritizing. So we're going to look for priority for discontinuation at the lowest benefit to harm ratio and the lowest likelihood of adverse withdrawal reactions. So that's how we may look at a med list of 25 and 30 drugs and say, where are we starting? And also to implement a discontinuation regimen with close monitoring to improve outcomes or onset of adverse drug events. And so when we look at implementing a discontinuation regimen, we're looking at tapering so that we're closely monitoring with each downgrade of dosage. When we want to focus in on the communication of a deprescribing protocol, we're going to look at communicating the rationale and the process. And what we do know is that patients and or their caregivers may in fact be more likely to engage if they understand rationale and process. And so when we say engage, we're talking about the individual expressing preferences. And so we're talking about deprescribing as a patient-centered, patient preference process. And so the rationale for deprescribing that we're communicating, such that risks of continued long-term use may not need to be necessary. So that patients, we need to communicate to patients that it is a good idea to perhaps prescribe a particular agent, and in fact, they may not need to bear the long-term effects in light of the possible therapeutic positive outcomes. And so it's an intricate, very delicate type of discussion that we need to kind of distill down and express so that they understand and are able to ask questions and engage their preferences, and then a formal plan can be devised. And then we're going to also be talking about the actual process, so the rationale behind it and the process as a communication to patients, family, caregivers, care partners. Now, I think time will allow us to go through this particular slide. It's a bit chock full, but I think it's one worth reviewing because it is specific to the nursing home. And Lou has given us this tip sheet with pretty clear guidance. And so overall, we're looking at when to review a patient's med list, what to do before discontinuation or tapering, how to start the taper with regard to monitoring and reassessing, and then clearly and really importantly, documenting the discontinuation trial so that it is recorded, it is part of the medical history. I did want to mention that on point number 3, with regard to life expectancy, there are some great tools like ePrognosis that can help us calculate those things, and so I did provide a number of resources at the end, and we can go through that as well, but just getting the deprescribing process down and then seeking out appropriate tools and resources that you can certainly customize for your particular practice is recommended. So Holmes and Todd emphasize that ongoing assessment of medications, once again, should be patient-centered. Reviewing that In fact, it is a delicate balance between the under-prescribing and over-prescribing, and because of that, it necessitates that regular clinician review. We need to consider the individual's preferences, as we mentioned, and specifically, they point out the issues of convenience and acceptability. And I think this speaks volumes to medication adherence, because regardless of whether a regimen looks, quote unquote, perfect on paper, the issue of the patient's acceptability of that regimen and whether or not it's convenient with regard to their lifestyle and their caregiving assistance is really important. And so we need to consider the individual's preferences, which may change over time, and we're doing this for that patient-centered approach. I think it's also important while we're speaking about this to mention that what someone is willing to tolerate at a particular point in their life or in their illness may change over time. And so it is important to, once again, really embrace the ongoing assessment aspects of this and truly make it a patient-centered approach. And also, with regard to current research, with all the guidelines, the current research really is aiming to empower clinicians with evidence-based guidance, and we're doing that to safely and effectively discontinue those agents, those potentially inappropriate meds that may be in the regimen, and we're doing this by the deep prescribing process. So it's not haphazard, there's a rationale, and there is a process. And encouraging patients, letting them know that it is a well-thought-out process and that there is input on their behalf is, I think, very reassuring for them. Next, authors Fritsch and Shelton told us about medication therapy reviews with regard to falls, risk-inducing drugs. So how can we reduce the risk of falls by focusing on medications? They looked at multiple factors, including medications that are commonly associated with falls, specifically among the aging population. And they told us the medication classes that they focused on. We see anticholinergic at the top of the list, CNS depressants, the antidepressants, benzodiazepines, sedative hypnotics, anticonvulsants, muscle relaxants, opioids, and antihistamines, specifically the diphenhydramine and the doxylamine. Cardiovascular agents, antihypertensives, and other cardiovascular agents, and the endocrine class, specifically insulin, phenylureas, and long-term metformin. So they noted what Castile had reported, and that is that pharmacists' recommendations for safer alternatives were found to reduce falls risk without compromising the achievement of desired therapeutic goals. So when they speak about the pharmacist's recommendations for safer alternatives, they're referring to not only the pharmacological alternatives, but also those non-pharmacological alternatives. And so we did mention the one in the ICU, but also with regard to community residing individuals, we're talking about lifestyle changes, we're talking about even physical therapy. There are a number of, interventions that can be recommended in place of medications that are placing individuals at risk that will not compromise achievement of desired therapeutic goals. And so this is where that comprehensive approach comes into place, and this is where that interprofessional engagement comes into place. It also supports the engagement of teams, interprofessional teams. It also, in my opinion, underscores the need for the educational process to include multiple disciplines as well, so that when they are in the workplace and they are in their practice setting, it is a natural opportunity to collaborate and really provide that, that full benefit to the individual, not just through medications alone. So Frisch and Shelton spoke to us about the pharmacist as a key facilitator in falls risk assessment. And in their contribution, which I've cited, it's the second citation at the bottom of the screen, they have in fact addressed a pharmacist assessment for falls. They've also provided an operationalizing pharmacist-conducted falls assessment. They did so regarding a variety of settings. And so in the hospital, if you can imagine, the pharmacist assessing for fall risk right in the ER, where very often we see frail individuals that are either presented to that setting because of a fall, or, excuse me, or we have their medication list available that we could scan for potential risks of falls. We also see the post-acute long-term care setting, where we would see the use of the MDS, the minimum data set, available to us to really identify risks, identify perhaps strategies that can be implemented in this individual to decrease the risk of falls. We also, they also noted the outpatient arena, where Medicare annual wellness visits do provide opportunity for a review and a risk assessment for falls, and that was through the 2015 Falls Free National Action Plan. And also in the community setting, where falls risk-inducing drugs, or FRIDs, can in fact be a component of medication therapy management services by the pharmacist. So I have provided some additional resources here that I would like to just review quickly, and that is the Choosing Wisely. Many of you may know them. It is so worthwhile to go through. It really enables a clinician to do that patient-centered approach by communicating with individuals. It helps with the deprescribing protocol, and it really helps make it patient-centered. Also, I did provide another reference example of deprescribing with a medication class, the PPIs, the proton pump inhibitors, simply because they really are so omnipresent, and this gives you a cue in how to proceed. The Deprescribing network, further down on this slide, is out of Canada. Really terrific algorithms to give a sense of how to proceed. And I also highly recommend the anticholinergic cognitive burden scale. You may not necessarily need to use this one in particular. I find it very helpful, but some type of anticholinergic scale where you can actually rate and score the agents in a med list, because I do think that with regard to cognitive impairment, it really helps us in terms of eliminating the drugs that may be easiest at the beginning to kind of rate them on a scale, and it is a validated tool. And then also e-prognosis, which once again can really, it provides videos, and you can actually watch communication between clinician and patient that's done in a very respectful and compassionate manner. And so I would highly recommend looking at those as well. So I do hope that I've piqued your interest to delve deeper into the evidence, the insights, and some of the recommendations that the clinicians in this clinics project have shared. And I also, possibly would consider another webinar so that we can address some of the other topics that were discussed in this large comprehensive project, like antibiotic stewardship and some of the managed care strategies, and also possibly pharmacogenomics, from our clinics project. So we'll see if that's something that can be accomplished. But I have provided these slides for you so that you can read the topics that were addressed. You can see the authors that participated, and again, look forward to possibly more another webinar addressing some of these issues regarding polypharmacy moving forward. So I do thank you all for your time and attention, and I wish you continued success.
Thank you, Dr. Zagaria, for sharing your expertise with our participants. I'd like to open our question and answer session. If you'd like to submit a question via the Q&A box, you may enter it now. We'll pause for a moment for our first question. And we do have a question that came in, and it reads, when you speak about preventing delirium and also transition of care, is there a class of medications that a team could focus on first to, quote, get the ball rolling, so to speak?
Sure. Yeah, this actually, this question speaks to the point that I was making earlier regarding the, in my opinion, the anticholinergics, and I'll tell you why. To start, I would just like to mention that naturally we're going to prioritize. So when you're looking at a med list, you're going to really go for the most risky agents in terms of thinking about deprescribing and, the transition of care approach. So that being said, the priority is important, but I would say that in my experience, anticholinergics are really a great way to start or to even instruct other disciplines to keep their eyes open about. And what I mean by that is, if you're going to do an interprofessional team approach, in addition to having pharmacists review a med list, you can certainly train other disciplines and other teams to focus in on eliminating anticholinergic burden in our seniors. And so again, looking back on that comment by one of our contributors regarding the emergency room, that is a wonderful intervention that can take place, where you're going to then look at the med list, focus in on the anticholinergic burden, try to eliminate those agents that are the most offensive but would cause the least problem in eliminating from the regimen. And once again, take a very, very conservative, slow, gradual approach so that you really can assess, monitor, and document any improvement over time with the withdrawal of some agents with regard to a number of things that can, manifest with these anticholinergics, one being, mild cognitive impairment, but also those physical, distressful complaints like constipation and, dry mouth and, discomfort with the dry eyes. And so I think those really, the anticholinergic group can really provide a great starting point. The other thing is, besides just the purely anticholinergic agents, there are a variety of agents that have the anticholinergic properties. So, we're going to definitely talk about antipsychotic agents, so we would, kind of avoid the ones that can really, promote delirium. So, like olanzapine or haloperidol, those may be the least preferable agents that you would want to use because of anticholinergic effects. Even the NSAIDs have that anticholinergic component. So even though we're avoiding their use in the elderly anyway, it's something to bear in mind, especially when you're training other disciplines to kind of be on the lookout to eliminate or not recommend some of these agents in our population. I think that approaching this with outpatient clinics, approaching it with caregivers, just looking at some of the advertisements on the television regarding the promotion of certain allergy medications, just the thought of introducing agents that are used that have even mild anticholinergic effects, when we use them long-term chronically and don't eliminate them over time, they can be problematic. So I think it's a mindset, and I think the anticholinergic group would be a terrific place to start. Again, I did mention the proton pump inhibitors, so if you have an opportunity to take a look at that resource, that would be great. And also corticosteroids. That would be another category, depending on the reason they're being used. I think it's really important to have that ongoing assessment and modification in dosage if possible. So a tapering over time, intermittently, that could certainly help quite a bit with our elders.
Thank you, Dr. Zagaria. We do have another question, and it reads, given the trend you mentioned regarding an increased use of over-the-counter supplements and patients purchasing meds online, can you comment on the risk of counterfeit meds and polypharmacy, and how do we know what we're dealing with?
Sure. Well, the one slide that we did look at regarding our contributor Levy spoke about the trends in use, so we did see that the supplements were increasing. So I would approach this from two ways. First would be the non-FDA approved agents, the ones that are not necessarily standardized, and we don't necessarily know what they contain, and they may be contributing to the risk of polypharmacy. So these are medications that are on the shelf in stores, but we're not necessarily able to 100% identify their content. The other is the actual prescription medications, and I think what we're finding now, once again, is the real risk of counterfeit and adulterated medications, especially purchased online. So the World Health Organization, because this is a global problem, they have actually put out, if you go online and search World Health Organization for a patient checklist with regard to buying drugs online, you will be able to obtain that and then use that perhaps in a counseling session, or really give it to all patients just as a point of information which they may pass along to others, even if they're not purchasing meds online. But it addresses things like, when you get a package and you're buying these drugs online, what are you looking for? So it will say check the seals, make sure that the inside packaging matches the outside packaging, like lot numbers and so forth. And so it gives a whole variety of questions that you can provide to your patients so that you're, promoting their safety and really raising their interest and alerting them to the problems that are occurring with purchasing meds online. The other thing, in terms of the actual question, the integrity of the product, it's really, the problem has been around for quite some time. I've recently read something regarding testimony that dates back to 2003. So this is not a new problem, and the scary part is that it is getting worse. So the FDA has developed a toolkit. So once again, if you go online and look up FDA toolkit, it's related to the medical products supply chain, and that will talk about best practices. It will talk about what the legislature is doing. It talks about safety concerns, and it also talks about the things that are being implemented in the acts that will kind of phase in over time, starting previously and evolving all the way through to like 2023. So there are things in place now that are being done by our government to really target this problem. But I think as healthcare clinicians, healthcare practitioners, really we owe the public at large some kind of guidance, especially pharmacists, to let them know about this danger. And, if they think they're saving money by going online, they may in fact put themselves at greater risk.
Thank you, Dr. Zagaria. Unfortunately, we have run out of time for questions. We would like to thank Dr. Zagaria for presenting this exciting informational webinar activity, and we hope that you'll be able to use what you learned today in your area of practice. At this time, I would like to thank our presenter and today's audience for participating in our webinar. Thank you for joining us. I hope to see you at a future webinar.